I'm going to be presenting about the role of ablation and sympathectomy in arrhythmias from the right ventricle. One of the common diseases that causes arrhythmias from the right ventricle is arrhythmogenic right ventricular cardiomyopathy or dysplasia. It's an inherited form of RV myopathy, mainly due to mutations in desmosomal proteins. There's a high prevalence of arrhythmias from the right ventricle. The histopathological hallmark is fibrosis and fatty replacement of the right ventricle. The diagnosis is made by using the modified task force criteria. Most right ventricular dysplasia patients present at young age and are usually high-level athletes, and there's a good correlation between the level of exercise and the arrhythmia. If you look at what causes ventricular tachycardia in the RVC, it's different depending upon the stage of the RVC. Early RVC is a high prevalence of rapid ventricular arrhythmias, usually ventricular fibrillation. It's called the concealed phase, where there is not many structural changes in the right ventricle. The onset often happens during exercise, and beta blockers appear to be highly effective. However, later phases of the right ventricular cardiomyopathy is mostly scar-mediated reentry. It's an established disease at that point. Not much change happens over a period of time. Recurrent sustained ventricular tachycardia is the rule. That stage, antiarrhythmic drugs, catheter ablation, or sympathectomy are usually very effective. Here's shown a 7-day recording, continuous recording using a Zio patch in a patient with ARVC. So you can appreciate that the number of PVCs shown as these bars are much higher during the wakeful time compared to during sleep. And this is a classic pattern seen in early ARVC. However, as time goes by, the number of PVC count remains stable throughout the day. Here's again, during an EP study, giving a high dose of catecholamine infusion, isoproterenol, given at 45 micrograms per minute for 3 minutes, is not only useful in diagnosis, but also uncovers polymorphic PVCs and also sustained monomorphic VT in ARVC, suggesting a role of catecholamine-mediated ventricular arrhythmias in these patients. The electron-atomic substrate in the ARVC is often epicardial, often rises in the subtricuspid region. Here's an RAO view of the electron-atomic map. There's a pulmonic valve and the tricuspid valve right here. As the disease progresses, there's more and more scar formation, mostly perivalvular, and extends all the way around the valve in the late stages of the disease. What are the common indications of VT ablation in ARVC? Usually recurrent ICD shocks, VT following failure of drug therapy, incessant ventricular tachycardia, and occasionally PVCs with symptoms. The circuits are often epicardial, so often requiring an epicardial approach. Arrhythmias are catecholamine sensitive. It's very important when planning sedation or anesthesia for these patients. Multiple VTs is usually the rule. There's a predictable scar location, and most people need more than one procedure, especially if the first procedure was an endocardial-only ablation. Here's a classic scar in ARVC. This is an RAO view and it's an LAO view. As you can see, there's a peritricuspid scar noted, and often when you map these patients as an EnSite precision map, you see this rotational activity right around the perivalvular region, and this significant conduction slowing around this region, also harboring the reentry. Often pacing within these regions lead to multiple exit sites, and each of these can correspond to one particular VT morphology. So multiple VT morphologies arising from the same circuits. There are many studies published on catheter ablation. The largest study was recently published by the Penn group, which showed significant VT-free survival of about 77%. Our group published in a large cohort of patients, in 87 patients, where clinical VT was ablated in 82% of the total acute success of 47%. But this is post-endo and epicardial procedures. When we did a significant number of epicardial ablation, the acute success rose to 97% with 83% 6-month and 76% 1-year survival. So as endocardial-only ablation is high failure rate, endo-EP ablation appears to be significantly better in these patient cohorts. What happens when ablation fails? There are options available. Sympathectomy is emerging as an important option for patients with recurrent monomorphic ventricular tachycardia and also polymorphic VT. The other, renal denervation and radioablation, are currently in a research mode. We know the neurostimulation can induce lethal arrhythmias even in normal porcine hearts. Here's the group from UCLA showing left stellate ganglion stimulation resulting in ventricular fibrillation porcine heart. International Cardiac Sympathetic Denervation Collaboration published this recent report of predictors of VT ablation and showed a significant advantage for bilateral denervation compared to alone. We've performed sympathectomy in ARVC patients and found significant reduction in ventricular arrhythmia burden over a long-term follow-up. 4 of the 8 patients that we've performed sympathectomy on had absolute no recurrence of ventricular arrhythmia during follow-up, and some had a single ICD shock or a couple of ICD shocks during follow-up from a prior multiple VT ablation episodes, multiple VT episodes before sympathectomy. Again, another important advantage of sympathectomy is a significant reduction in antiarrhythmic drug therapy following the BCSD, which is especially valuable for patients with ARVC who often are young and of a very athletic background, who often don't tolerate antiarrhythmic drugs very well. This is another example of a patient with a high burden of PVC synecdoche and recurrent monomorphic VT who had sympathectomy and post-sympathectomy. As you can see, the number of PVCs recorded the day after sympathectomy is significantly reduced from baseline. This is another patient with ARVC who had multiple episodes of cardiac arrest despite defibrillator implantation and multiple antiarrhythmic drugs, who underwent sympathectomy after a failed open chest cryoablation, and post-sympathectomy he had significant reduction in arrhythmia burden, remains arrhythmia-free even after 5 years of sympathectomy. So I want to conclude by saying ARVC patients respond well to catheter ablation. Epicardial ablation is often needed in these patients. Beta blockers remain a cornerstone of therapy because most of these arrhythmias are calculin sensitive. Epicardial ablation, again, is a preferred approach in these patients. Repeat procedures are not uncommon. Sympathectomy in select patients significantly reduces arrhythmia burden in ARVC and should be considered in patients who fail catheter ablation or young patients with recurrent polymorphic ventricular tachycardia. Thank you.